Could we lower this like an inch?
Oh, absolutely. The little control is right over there.
Oh, great. Okay.
So are we going to have her use this mic or that one?
I think because I'm going to use notes on paper, I'll stay here, so this should be good, but...
Get you anything? Oh, you've got some water.
I do.
I'll just hide that.
Do we have any estimate of how many folks will be coming?
Typically we have 15 to 20.
Okay. Great.
You know, but it varies.
Sure.
So we're going to drive the camera a little over.
Okay.
Yeah, it's time change Mondays.
Oh, yeah.
And I'm not sure if that's what happened with your 9:15 this morning. She said she was on.
Oh, yeah, it's those, I mean, it's always hard to predict. Yeah.
How's it going?
Great.
No questions?
I don't think so. Hopefully you all will have questions for me after this.
Good.
Yeah.
That's, people usually do have questions.
Okay, good.
It's hopefully we'll get people here. It's also a time when people are teaching, so
Okay.
not all the faculty will be able to come. But
Sure.
you know, that's always the case, and we do record it, so people do look at them later.
Great.
So,
That's really nice that, you know, you have that capacity to...
are you
Yeah.
comfortable with that, Mike?
Yeah, and I think I'm going to use the notes on paper, so I'll try and stay put so people can hear me.
Great.
Yeah.
So at 11 o'clock when you're finished, I'll come back down.
Okay.
And then I'll take you to your next
Okay.
stop.
All right.
Thank you.
Thank you so much.
So here's our camera shot.
Okay.
If you're
It's
right on the
up
mic.
there.
Yeah, we are running
Okay.
from camera 1, so that one on the left. Right, so that's
The one on my left.
correct.
Okay.
No, it's, of course it's not.
Good with that?
Yeah.
Okay. Get back to your presentation. And if you
Wonderful.
had to do anything, you can use the mouse in this.
Okay. Okay. Thank you so
and they
much.
know how to reach me if there's trouble.
Browse through the food thing.
Morning.
We're all on this side. Some of us have to leave a little bit early to get to the next meeting, so. That's why I'm on the edge.
Please all sit over there. Start to balance. Okay. No, actually, until you get through there, until you override, which is really still on my desk. Sorry. I try not better not to. I have no such rule.
Hi. I think so, yeah.
Not a lot.
Hi, how are you?
Dr. Green, nice to meet you.
Nice to meet you, too.
Willis. I work as the Associate Dean for Academic Affairs.
Wonderful.
Nice to meet you.
You too, thanks. Sure. Okay. I'll try to make eye contact with the camera.
Good morning, everyone. Thanks for coming today. I'm really pleased to introduce and welcome Dr. Maddie Green. She is a faculty candidate for our tenure track faculty positions, and we're glad that she's here today. Dr. Green has baccalaureate degrees in Women and Gender Studies from Georgetown and a baccalaureate in nursing from the University of Pennsylvania, and she received her PhD in nursing also from the University of Pennsylvania. She's currently a postdoctoral fellow in Health Disparities Research Scholar with the School of Medicine and Public Health. Her research really is looking at mechanisms that cause and perpetuate disparities in sexual and reproductive health. So, welcome, Dr. Green.
Thank you so much.
And just as a quick reminder, we are video capturing this today, so if you have questions or comments, please use your microphones. Thanks.
Thank you so much for that introduction, and thank you all for being here to hear about my work and about my vision for this faculty position in the School of Nursing. I would love to especially thank the search committee for inviting me and to Mary for all her help organizing my visit. My research broadly aims to understand the healthcare-related drivers of sexual and reproductive health disparities, and it also aims to increase the capacity of nurses and other healthcare professionals to more effectively address those disparities. Here's a brief outline of what I'll be sharing with you today. First, I'll give some grounding in disparities in sexual and reproductive health, both going over the broad scope of the problem and also my specific research agenda. I'll tell you about two specific studies that I think are good exemplars of the kind of work that I do, both in terms of specific research questions, as well as with the methodological approaches that I use. Then I'll outline my research agenda going forward, including my plan to leverage strategies from dissemination and implementation science to address the disparities that I'm interested in. And finally, I'll tell you a bit about my vision for working here at UW Nursing specifically. But before all that, I'll share with you a bit about my journey to pursuing a career in sexual and reproductive health disparities. So as Dr. Zahner said, I received a bachelor's degree in gender and women's studies from Georgetown University. And during that time, I began to learn theoretically and intellectually about how social and political structures influence reproductive health. After graduation, I then worked as an AmeriCorps volunteer doing health education on Chicago's West Side. This was my first experience with patient care, and this is where I really began to see the day-to-day impact of those political and structural forces on people's health. Our work as health educators in some ways began to feel futile in the face of things like intergenerational poverty, housing instability, and living in a food desert. So it also helped me decide that nursing was a profession and a field through which I could enact change both at the individual and also structural levels on these problems, given that nursing has this rich history of patient and community-oriented approaches to health. So I then completed my BSN at University of Pennsylvania, where I was very lucky to be accepted into the Hillman Scholars for Nursing Innovation program, which is a direct entry BSN to PhD program. This program allowed me to incorporate scientific inquiry and asking big questions throughout all the levels of my nursing education and then clinical experience. I completed my PhD there at Penn in 2017, where I had focused training on health disparities and equity, as well as on vulnerable women, children, and families. And since then, I've been a postdoctoral researcher here at UW-Madison in the School of Medicine and Public Health in the Health Disparities Research Scholars Program. And since being in Madison, I've worked really hard to start establishing relationships with community members and other stakeholders in the area, including both clinical entities and providers, as well as the state and local departments of health. And this really is to help ensure that my research is grounded in the needs of the community and is responsive to what's actually happening at the bedside and in those communities. Stated in a very broad way, the aim of my research is to improve the capacity of healthcare providers, including nurses and health systems, to combat sexual and reproductive health disparities and to improve the sexual and reproductive health of marginalized populations. This graphic on the right of the slide highlights that to achieve this aim, scientific evidence must be generated and then leveraged into both practice and policy changes that can address disparities and inequities, and that those practices and policies will then, should in turn support the continued generation of useful evidence. Since my research aims to address disparities and to reduce inequities and promote equity, I will tell you how I define those concepts in my work. Health disparities are preventable differences in the burden of disease, injury, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Two important components of this definition highlight that disparities are not just differences between groups of people. but that there are differences that could be prevented with specific interventions, and that the causes of these differences that we call disparities is some aspect of social inequality. Health equity, then, is the condition in which everyone has that opportunity to achieve optimal health, and in which no one is disadvantaged from achieving their health potential because of their social position. So this image also shows us the difference between concepts of equality and equity. In the panel on the top of the image, we see an example of equality. A variety of individuals have access to the same resource, in this case a bicycle. But because this resource is built for a specific type of person, it can become totally unhelpful to, for example, the person on the left who uses a wheelchair, and even potentially damaging or dangerous to the person on the right, who in this case is a child. The panel at the bottom of the image shows us equity. While these individuals may not all be moving at the same speed or even going to the same destination with their health, they each now have access to the resource that is safe, helpful, and usable to them as individuals. There are lots of ways to understand social inequality, and race and ethnicity are probably the most robustly studied in terms of well-defined population groups. But individuals, of course, experience various levels of social advantage or marginalization on many axes, including what's commonly studied are race, class, and gender. My work takes these factors into account, and the work I'll present today focuses on population groups that are defined by and that experience social marginalization in terms of sexual orientation and then in terms of geography. This infographic is borrowed from the Health Equity Institute at San Francisco State University, and again displays the multitude of social, environmental, and structural factors that influence individual and population health, and which help explain some of the root causes of health disparities. We all, I think, understand how important these social determinants of health are. My work focuses specifically on how healthcare delivery and health systems intersect with those social determinants of health, and how we might build capacity as nurses to address social determinants more effectively. What all this, I think, adds up to is an assertion that without specific attention to these problems, health service and health system interventions that may be effective overall may actually simultaneously widen disparities that already exist. This has been demonstrated to be true in a variety of arenas, and specifically with regard to sexual and reproductive health outcomes. As nurses, we've also been on the forefront of this kind of work for many years and have a rich history of focusing our attention on the most vulnerable groups, as well as working to promote health within both the constraints and the opportunities of day-to-day life. And as the front line of much of sexual and reproductive health service, we have major potential to design impactful interventions that address disparities in this area of health. So as the WHO defines it, sexual and reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of disease in all matters relating to sexuality and to the reproductive health system. This definition of sexual and reproductive health implies certain rights that individuals and families have, and these include the right to information, the right to have access to safe, effective, and affordable methods of family planning, and the right to appropriate health services that enable people to experience pregnancy and childbirth safely. Disparities occur all along this continuum of sexual and reproductive health needs. And negative sexual and reproductive health outcomes can be especially important because they can impact the entire life course and even the health of future generations. These patterns are also reflected in work that uses the life course theory, the weathering hypothesis, and in work that's focused on promoting healthy aging as well. As I think many of you probably know, the U.S. consistently has far worse maternal health outcomes than many other comparable industrialized countries. And there's also evidence of stark disparities across racial and ethnic groups, with Black American women shouldering the heaviest burden of maternal mortality in the United States. Not only have we not been successful yet at addressing racial, ethnic, or socioeconomic disparities in maternal outcomes, but these issues, specifically with regard to maternal health, are becoming more and more visible to the public. Additionally, though, increasing resources are being funneled into addressing these disparities, including things like the NIH declaring LGBTQ populations a health disparity population, as well as legislation being introduced at the federal level to address those stark disparities in maternal morbidity and mortality. So the central problem or question that drives my research is how to get high-quality, evidence-based, effective, and community-responsive care to populations that experience social marginalization. And as I've said, I focus on two major factors that influence our ability to do this. First, I explore how bias and discrimination, both outside of but also within healthcare systems, may act as a barrier to receiving high-quality care for marginalized populations. Second, and related to this problem, I'm concerned with how variation in the implementation of evidence-based care may contribute to the higher burden that marginalized populations already carry. I'll share with you today two specific studies that address each of these two factors, and they also demonstrate the breadth of research methods that I use to answer these questions, including both qualitative inquiry as well as quantitative analysis of existing data. So the first study I'll talk about sought to understand sexual minority women's experiences with contraceptive care, and it reveals some of the mechanisms by which bias and discrimination find their way into healthcare services. This work has also recently been accepted for publication in the journal Obstetrics and Gynecology. So to understand this particular disparity, it's critical to know that sexual orientation is actually a multifactorial concept that's most often understood to have three major components that include identity, behavior, and attraction. In this study, we defined our sample in terms of sexual identity, expecting and also finding a wide variety in terms of sexual behaviors and attractions of our participants. So for this study, we define sexual minority women as women who were assigned female sex at birth, or cisgender women, who identify as something other than heterosexual. And these identities can include gay, lesbian, bisexual, queer, pansexual, many other non-heterosexual identities. The study was motivated by several recent findings in the literature suggesting that sexual minority women do want and need access to contraceptive care services. A recent paper by Bethany Everett shows that sexual minority women may constitute up to 1 in 3 clients who present to family planning clinics. However, these women are likely to face significant and unique barriers to contraceptive care that they want and need, suggested by other findings that sexual minority women may actually have increased risk of unplanned pregnancies throughout both adolescence and early adulthood. So given these findings, I aim to describe a group of young sexual minority women's experiences in contraceptive care and to understand how they navigated their sexual identities with contraceptive providers. My research team conducted 5 focus groups and 11 individual interviews with young women who lived in Madison, Chicago, and Salt Lake City. And our sample included women with a diverse set of sexual identities, although our participants were largely white and well-educated. The most salient theme that emerged from this work was our participants' experiences with disclosing and discussing their sexual identity to providers. As a note, collecting sexual orientation data and asking all patients about their sexual identities has been established as a best practice. It's well supported by evidence, and it's been promoted by many healthcare professional organizations, including the American Nurses Association. However, our findings here and other work has demonstrated that not all providers and not all clinics are implementing that recommendation, and that revealing a sexual minority identity can actually act as a significant barrier to receiving the contraceptive care that you may need. So from our findings, we identified 3 major stages during a clinical encounter during which sexual minority women need to navigate disclosing their identity to providers. First, they listened for whether providers asked at all and how providers asked about sexual orientation. Second, they weighed information, both information they had gathered before the visit and during the visit in real time, to decide whether or not it would be strategic for them to disclose their identities. And finally, they described providers' responses when they had disclosed that they were not straight. Not only did many of the participants report that they'd never or rarely been asked about their sexual orientation, they also described that when the provider made heteronormative assumptions, this could undermine their trust in the provider or the provider's medical advice. So Joan, a 25-year-old lesbian-identified participant, said, "If they're giving me advice, medical advice or whatever, assuming I'm a certain way, even if it's still good advice, I'm not going to take it wholeheartedly unless I know that it's directed at me. If they don't know my identity, then it just feels like they're spitting out words, you know?" So virtually all of the participants in this study reported to us that they had carefully considered whether or not it would be smart to disclose their identities to contraceptive providers. And again, they weighed information that they gathered both before the visit and also during the visit in real time. So Addison put it this way: when you go to any new environment, but definitely somewhere where you're as vulnerable as a doctor's office, you're kind of doing the vibe test and assessing, is this a safe place for me to come out? How much do I reveal? Unfortunately, our participants also reported commonly that when they did disclose their identities to providers, misconceptions and assumptions about what they may or may not actually need in terms of contraception often emerged. So Beatrice told us, in our society, everyone is assumed straight until proven otherwise. Then it goes one way or the other. Either medical professionals are like, why aren't you on contraception? Because they assume you're straight, or they go the opposite direction where they're like, oh, you're queer, whatever, and then they completely ignore contraception. And several of our participants reported that providers assumed that their identity meant they had no need for contraception, as Beatrice is describing here. But also they commonly stated other misinformation, such as the idea that sexual minority women are at no risk for sexually transmitted infections or that they didn't need cervical cancer screening. So my findings from this study reveal that even one or a few negative encounters in contraceptive care or in healthcare more broadly could influence sexual minority women's future decisions about seeking care and their trust in healthcare providers and the health system overall. However, there were specific providers or clinics like individual student health clinics that were mentioned or Planned Parenthood that were known to provide competent care to sexual minorities, and the communities shared this information via word of mouth. Finally, our findings affirm these existing recommendations to collect sexual orientation data from all patients, and that data should include both sexual identity information as well as information about sexual behaviors. Taken together, these findings reflect not only the ways that bias finds its way into healthcare services, but also highlights gaps in the consistent implementation of evidence-based recommendations. The second study I'll share with you today is an ongoing one and is showing promising early findings. And this work addresses how variation in the implementation of obstetric care across geographic regions can disproportionately affect women who are already structurally disadvantaged, in this case by living in rural areas. So again, while most other industrialized countries have been able to decrease rates of maternal mortality, in the US, rates of maternal mortality have been increasing over the past several decades. However, mortality per se is still an extremely rare event. And for every maternal death, there are approximately 50 individuals who experience severe complications either at or shortly after the time of delivery. These are what we call severe maternal morbidities, and they include things like postpartum hemorrhage, unplanned surgeries like hysterectomies, sepsis, and many others. Because these severe complications are much more prevalent than maternal death, analysis of severe maternal morbidities is a powerful strategy to understand what might be driving disparities in this area. And severe maternal morbidities have also been on the rise in the US over the past several decades, as this figure from the CDC shows. Like maternal mortality, many severe maternal morbidities are largely preventable, which means that access to high-quality and evidence-based obstetric care might prevent many of them from happening. However, women who live in more rural areas are much less likely to live near a hospital with specialized obstetric care or even high-quality evidence-based obstetric care at all. So this is a map of obstetric critical care units in the green dots and maternal fetal medicine providers in the black dots. And as you can see, there are huge areas across the US where there's virtually no access to these high-level services. Additionally, low-volume birth hospitals, or those hospitals that deliver less than 1,000 infants per year, are much more likely to be located in rural areas. And as shown by the blue line in this graph, have also been shown to have births that happen in low-volume birth hospitals are much more likely to be associated with severe maternal morbidities. For this analysis, then, I aim to test whether the rural-urban gradient in the U.S. is associated with rates of severe maternal morbidities. And this takes into account both individual risk factors as well as county-level sociodemographic and healthcare access factors. So challenges with surveillance and tracking of maternal health outcomes remain in the U.S., but the revised birth certificate offers a really exciting opportunity to track certain maternal health outcomes. The revised certificate of birth was introduced in 2003, but has only been implemented in all states since 2015. And the revised certificate of birth added several measures that might help us track maternal health outcomes, including some specific maternal morbidities. The ones added to the revised certificate of birth that I'll use in this analysis include admission to an intensive care unit during the delivery hospitalization, unplanned surgical procedures, which again can include hysterectomy as well as other procedures, and blood transfusion, which we understand as a proxy measure for significant hemorrhage. For this analysis, I'm using data from births that occurred between 2011 and 2014 across all the states that had implemented the revised certificate of birth during those years. And the total sample of births is approximately 15.8 million. Because this work is ongoing, I don't have the final model results to share with you, but I will say that my early models are showing that these outcomes do vary in important ways across the rural and urban gradient. So for example, in this figure, you can see that rates of blood transfusion are significantly higher in birth hospitals that are located in micropolitan and rural counties. Admission to an ICU, though, does not seem to vary by the degree of rurality. So to continue to explore these patterns, I'm building a multi-level regression model that again will account for both individual and county level factors. And we're able to account for both specific medical risk factors for women, including maternal age, pre-existing and gestational diabetes and hypertension, previous birth history, as well as socio-demographic factors that might impact risk, like race, ethnicity, nativity status, and education and insurance status. We also use the area health resource file to control for measures of socioeconomic status and segregation within counties, as well as measures of access to obstetric care services. The findings from this work will shed light on concerns about birth hospitals in rural areas, including their differential access to resources like technology, to specialists who can support complicated births, including a highly skilled obstetric nursing workforce, and clinical decision support and training on best practice protocols. And these problems, again, are related to challenges with the dissemination and implementation of evidence-based practices. So taking all of this and others' work together, what my findings show is that wide variation in quality of care and the successful implementation of specific programs in maternal health is a major driver of disparities in reproductive health outcomes, since this variation is most likely to impact population groups and individuals that are already at highest risk. My current and near future work, therefore, addresses problems with the dissemination and implementation of evidence-based practices to marginalized groups. Dissemination and implementation science is an emerging interdisciplinary field of research that focuses on the study of methods and strategies to promote the uptake of interventions that have proven effective into routine practice, with the overall aim of improving population health. So recall the assertion that I made earlier, that when health service and system interventions do not specifically take the experience of marginalized populations or the existence of disparities into account, those interventions might actually widen disparities that already exist. Dissemination and implementation science holds major promise as a field that can inform research questions, insights, and strategies for addressing disparities in the delivery of evidence-based care. This potential has also been acknowledged by the NIH, and increasing funding is being funneled into dissemination and implementation related work. I'm currently using dissemination and implementation research strategies in a qualitative study that's been funded by the UW Institute for Clinical and Translational Research, and I'll also pursue further training and research funds for dissemination and implementation science through a larger career development award. So the qualitative study that focuses on dissemination and implementation that I'm currently working on aims to understand the implementation of prenatal care coordination in Wisconsin. Prenatal care coordination is a quite unique fee-for-service Medicaid benefit that is implemented at the county level across the state. And it aims to improve birth outcomes among high-risk women by facilitating access to medical, social, educational, and other resources. In attempts to evaluate the effectiveness of prenatal care coordination, findings from my research group in OBGYN have revealed significant variation and also major barriers to consistent implementation of prenatal care coordination across the state. And these two maps show examples of this. On the left, you can see that rates of any PNCC service delivery, which includes screening of eligible women, varies across counties from less than 10% of eligible women to over 70% of eligible women. The map on the right shows that among women who were screened into PNCC or who should be getting PNCC services, the rate of actual delivery of services to those women ranges from less than 30% to almost 100% of enrolled women. In response to these findings, I launched an implementation study of prenatal care coordination focused on counties in Wisconsin that serve racially and ethnically marginalized groups of women. And these groups include Black women as well as Native American women in Wisconsin. The study has three aims. First, to identify factors that influence program implementation in three such counties. Second, to describe the perspectives of program clients on the value and the implementation process of the program. And third, to employ the Consolidated Framework for Implementation Research, which is one of the more popular frameworks in this field, to generate immediately actionable recommendations from the findings of this study for county health departments as well as other implementers of prenatal care coordination. And this study has incorporated work with community partners, including state and county level departments of health, at every level of the study, from the design of the research question all the way through our generating innovative strategies for dissemination of our findings. Looking a little bit further forward, I also plan to leverage dissemination and implementation science strategies to understand and ultimately improve the implementation of perinatal regionalization across the U.S. Perinatal regionalization is a strategy that creates networks of hospitals, health systems, and providers to facilitate births happening in the right places. In other words, it's a strategy that aims to improve access to higher levels of care for individuals who are at high risk of severe morbidities or mortality. And like prenatal care coordination, perinatal regionalization has been implemented with a huge variety of resource investment, approaches, and strategies across different states in the U.S. And again, it's been implemented largely without specific attention to marginalized groups. Evidence about the effectiveness of perinatal regionalization is also mixed, and it's likely that successes or challenges with implementation is a major driver of its effectiveness. So I plan to submit a Career Development Award, or KO1, that aims to leverage dissemination and implementation science strategies to better understand perinatal regionalization and how it has or has not addressed and might have the potential to address disparities in access to obstetric services. On this slide, you'll see the way that I've mapped out the next few years in my career in a faculty role with respect to these major projects that I've described. So within this year, I plan to submit that training grant that I've told you a little bit more about and to complete data collection for the study on prenatal care coordination. Next year, I'll be focused on innovative dissemination strategies for the findings from that study on prenatal care coordination, and we'll begin the methodological training and dissemination and implementation supported by that KO1 grant. In 2021, I'll continue the focused training both on D&I methods and on perinatal regionalization efforts and begin to acquire the data I'll need for the research associated with that training grant. Then in 2022, I'll continue to pursue training in those areas, be actively working on the research funded by the K, and begin to prepare and think about an R01 that follows up on this work. And by 2023, I hope to be sharing findings, from this research on the implementation of perinatal regionalization and also to submit an R01 that follows up on it. Across all of this work, I'll be maintaining the collaborations I've developed that are interdisciplinary and cross-institution, as well as with community partners that include local and statewide stakeholders, such as nursing professionals who are actually on the forefront of all of this work in both the clinical and in the public health settings. Here at UW, the collaborations I've developed include Deb Arenthal and Ellen Hartenbach, who are in the Department of OBGYN, as well as Jenny Higgins, who's in OBGYN and Gender and Women's Studies. And I've also been very lucky to maintain a collaborative relationship with Tonda Hughes, who's a leading researcher in sexual minority women's health, and Margaret Passion-Wolf, who also works on sexual minority health at Columbia University. So I'll shift now to telling you about my teaching and mentoring experience and my vision for teaching and mentoring as faculty here at UW Nursing. My research and teaching are linked by a commitment to equity and diversity, and by the aims of fostering competence in health equity in the nursing profession and supporting the success of nursing students from diverse backgrounds. I was very lucky to have extremely rich and engaging teaching assistantships during my pre-doctoral work in both an undergraduate nursing research methods course as well as an upper-level health equity course for PhD students. I've guest lectured in many courses and across several disciplines, including what we think is the largest class on gender and health in the country in the Department of Gender and Women's Studies here at UW. I'm also currently teaching an undergraduate course on LGBTQ plus health and healthcare in the Department of Gender and Women's Studies, which has been an incredible experience. My teaching here at UW Nursing will make three major contributions. First, to support health equity inclusion across courses and throughout the curriculum. I've really been thrilled to learn more about the school's commitment to excellence in these areas, and I'll be thrilled to lend my own experience and expertise. Similarly, I bring clinical experience and academic focus on sexual and reproductive health, which I know reflects the interests of many students here. Finally, I'm deeply committed to developing students' critical thinking and other intellectual skills. And these are skills that will increasingly need to be called on in a dynamic healthcare system and healthcare environment that will enable nurses to provide excellent care in all types of settings. I'm really so excited about the opportunity to work at UW Nursing. I see the school really as exemplifying the Wisconsin idea to apply academic pursuit and research to actually solve real problems and to improve the health and quality of life of the citizens of the state and beyond the state. I really look forward to building more collaborations with many of the faculty who are already here. In terms of service both to the School of Nursing as well as to the nursing profession more broadly, I plan to make a significant contribution by mentoring students both from diverse backgrounds and those who are enrolled in second degree, accelerated, or direct entry BSN to PhD programs. My own educational background and experiences give me a unique perspective on how to thrive in such programs. I also plan to contribute my expertise in health equity and sexual and gender minority health to ongoing development of the concept-based curriculum here. And finally, I'll continue to pursue opportunities to serve in local and national professional organizations. I've served previously on the board of the nursing section of GLAMA, which is Health Professionals for LGBT Equality. And I look forward to developing deeper relationships with the Midwest Nursing Research Society and other nursing research organizations. I'd love to thank and acknowledge all of my collaborators and mentors who really have made my work possible, as well as, of course, the organizations and institutions that have funded the work that I've shared with you today. Again, a special thanks to the search committee for inviting me, and to Mary for all of her work putting my visit together. And I'll be happy to take any questions that you have.
Okay, any questions? You must have some. Yes, go ahead, Tracy.
Pleasure. I'll bring this mic. Sounds good. Thank you. Hi, Dr. Green. A pleasure to listen to you speak today. Excellent talk. Your work combined both attention to disparities in marginalized populations in addition to rural. And I saw you weave that through each of your studies uniquely. Your most recent work was more so focused on the marginalized populations. And I'm wondering if future work might also include that rural population, which also suffers from some challenges like you described. And then a second question, as a pediatric nurse practitioner, I think that that disparity in how we're reacting and what we're, the experience that our young individuals bring to their first visit to healthcare, and when they're weighing how they're going to expose their character, their identity, their attraction, I think it begins significantly before they become young adults. And I just wonder if you have any plans to look at earlier experiences of some of our adolescents at that time.
Yeah.
Thank you.
Thank you so much. Those are both such great questions. In terms of this distinction between the work that's focused on the rural-urban differences and other marginalized groups, I actually think about the places where we live as one factor that might be considered an aspect of either privilege or marginalization, right? So people who live in more rural areas who have decreased access to excellent, high-quality healthcare services, we may think about that as an aspect of marginalization, right? And of course, we don't experience the place where we live independently from the other aspects of our identity that might give us certain levels of privilege or marginalization, right? So I do think that while my work focuses maybe more specifically on one aspect of marginalization in each project, I think about these things as all very much part of the same set of concerns, and how where we live, who we are, and other social and political and structural forces, sort of how all those things combine to drive our ability to achieve optimal health, right? So I suppose the more direct answer to your question is yes, I hope to continue to pursue sort of all of these various aspects of drivers of health, yeah. I think your question about sort of going back further in the timeline of how people experience healthcare is a really good suggestion. And I think you're right that people's expectations about their experiences with healthcare providers are set much earlier in life. There is something interesting about early adulthood in terms of gaining more independence with access to healthcare providers. And we certainly saw that reflected in the study that I shared with you today. Our participants described really interesting patterns of how they had strategized about this over the course of their lives, including their adolescence and also, currently in their sort of emerging adulthood stage. There's lots of work being done on adolescent LGBTQ populations and health, and some of the early work that showed that there are higher levels of unintended and unwanted pregnancies in that population, that work was really focused on adolescent women. So we know, again, that these problems are starting much earlier. And complicated interaction with family and insurance coverage that's often connected to parents who may be more or less accepting of this variety of sexual identities definitely complicates that question in a really important way. Yeah, so thank you for that suggestion. Yeah.
Chris. Diane.
I echo Dr. Snedden or Tracy's comments. I really appreciated how you connected the dots between where you've been and where you are and where you might go. And I realize that you're studying different issues, with different populations, with a common theme. I wonder, are there any theories or conceptual models that help pull some of the ideas that you have together that you find useful or not so useful?
Absolutely. So, too many models and theories that I find useful. I think one that I come back to all the time is intersectionality, which probably won't surprise anyone in the room. But I think what's nice about thinking about these problems through a lens of intersectionality is that it's a theory that's a little bit less prescriptive, but it describes the way that different pieces of identity and experience come together for individuals, right, in unique ways. So that's something I come back to a lot. I've also used, my dissertation work used Anderson's behavioral model of healthcare service utilization, which is, of course, a more prescriptive model, but it helps to describe the larger structural factors as well as the individual factors that might impact a person's decision to seek a particular kind of health care. And I think both kinds of models can be really useful, with the caveat that we use them to generate more nuanced and more ideas about how these pieces come together for individuals. So yes, there are many.
Thank you.
Yeah.
Hi, you've got a really important area of work, and it seems like the KO1 is probably a logical next step for you. Can you tell us a little bit more about your plans for that award, both mentorship and research, and then what's your backup plan if it doesn't get funded?
That's a great question.
Not that that's going to happen.
No, that certainly won't happen. Sure. So in terms of mentorship, I certainly hope to continue working with Deb Arenthal, who is just an incredible resource on all of these issues in terms of broad policies and programs across the United States as well as in Wisconsin. So she'll certainly be on the mentoring team for the K. And I think, dissemination and implementation science is really going to be the focus of the training of that grant. And then continuing to learn about what the sort of historical perspective on perinatal regionalization will be another significant investment of time and resources, especially with folks at the CDC who have sort of led the charge in promoting such interventions. And putting those pieces together will be the bulk of the research that I hope to do with the grant. Probably mostly descriptive in terms of how different states have implemented the strategy and then what the outcomes look like in those states before and after they implemented perinatal regionalization. One interesting piece of it is that most of the efforts in perinatal regionalization have been focused on infant outcomes and neonatal outcomes, which is a pattern that happens across lots of maternal child health work. And Wisconsin has a really interesting and is in some ways leading the way on promoting obstetric levels of care designation. The American College of Obstetrics and Gynecology has promoted that we need to also focus attention on the maternal health outcomes specifically. So I think that's something I'll be able to do really well being here in Wisconsin, is to focus on the maternal health side as well as the neonatal side. In terms of a backup plan, I think because more people are recognizing that this is a really important area, there are lots of other opportunities for funding. The Institute for Clinical and Translational Research seems to really care about these kinds of issues. I am lucky to now be connected to the Hillman Foundation through the Hillman Program in Nursing Innovation, and they're really invested in these kinds of nursing-focused and nurse-led interventions that could have powerful impacts on really big, complicated health problems. And there are lots of other organizations that I would look to for funding. Robert Wood Johnson Foundation, I think, would be another good place to look. Yeah. Thanks.
Yeah, I want to follow up on your comment about intersectionality. So you're looking at sexual identity, sexual activity, and also rural location. Are there other things that you think you might want to, because intersectionality would involve a much wider range of
Absolutely.
questions.
Yeah, and I think this is where it's really important to, it's important to me, and I look for this in others' work as well, to think about some of the most important drivers of health outcomes that we know exist in all work, right? So I always aim to take into account race and ethnicity. I always aim to take into account education level, socioeconomic, various measures of socioeconomic status, which is complicated. We may think of it in terms of income, we may think of it in terms of profession, and education, of course, in this country is a reflection of socioeconomic status as well. So, yes, I think my approach and the way that intersectionality informs my work is that those things are always underlying. And any conclusion, so I wish I'd had more time to talk about sort of the limitations of a lot of work on sexual minority individuals, and especially this area of sexual minority women's reproductive and sexual health. So much of the data that's been generated is really reflective of upper middle class, well-educated white women, which tells us, there's been really important information generated, but it tells us basically only about that group of sexual minority women. And so these are concerns that I have that inform all the work that I do. Yeah.
Thank you for an excellent presentation. I definitely see your passion for research, and I would like for you to talk about your passion for teaching and what you see in terms of promoting an excellent student experience, any teaching learning principles that you draw upon, and your vision for that. You gave very specifics, which were important, but just in more general.
Sure, yeah, thank you for asking that question. I do love teaching, and I've been having such a wonderful time teaching this course in Gender and Women's Studies this semester. I find that students often generate really exciting ideas and engage with these topics really deeply and really well. My educational experience informs a lot of the way I approach teaching and that I approach students. I've been lucky to have a huge variety of educational experiences and approaches to what learning means. Having a bachelor's degree in a humanities field, really highly valuing the processes of close reading and communicating ideas through writing. Those are things that I bring into the classroom, and that I think the nursing profession could really benefit from a bigger focus on. And those are skills that I hope all of my students keep their attention on throughout their work. I think the way I think about my role as a teacher is really to build a lot of structure so that students can do their own intellectual work. So, that looks like designing a variety of assignments, assigning readings that are both the core competencies and the core, the sort of canonical information about a particular issue, but also what's on the cutting edge and what questions people are asking. And making expectations clear and keeping expectations high, I find that students rise to meet those expectations. And I think, so my approach is that building that structure really thoughtfully and well will allow students to do the more interesting work of developing their intellectual and clinical skills in a field like nursing too. Yeah, thank you.
Can you hear me? Yeah, okay, this is on. Okay, well, Dr. Green, first of all, thank you for a most impressive presentation. I'm going back to your comment, your earlier comment that prompted the question, and here my comment says an observation, not a criticism. So you mentioned that most, if not, well, the majority of research is on educated white females. And I noticed that your qualitative research was educated white females. So I'm wondering what plans or thoughts you have about moving that aspect of your research program forward in terms of identifying and being more inclusive in underrepresented voices.
Yeah, thank you. That's a really good question. So the findings and the study that I presented today on my work with sexual minority women is actually data that comes from a larger study about pregnancy risk and experiences with contraception, as well as the kind of sex that could lead to pregnancy in a group of young sexual minority women. So in a certain way, I wasn't in charge of designing the sampling. And I have another set of data from a study that I completed using participants from Tonda Hughes' larger longitudinal study that does have a much broader variety of racial and ethnic identities, as well as education level, socioeconomic status, that I hope will start to bridge that gap in terms of describing a variety of LGBTQ women's experiences. I think the interesting thing is that because of the country that we live in and the social and political structures at play, the places where people go for healthcare actually reflect differences in racial and ethnic groups, as well as in socioeconomic status. And that has to do a lot with how those things influence where people live and what people have access to. And so a lot of these studies have recruited samples like through a specific clinic or through a specific social organization. And so they then end up with samples that are sort of homogenous in those areas. There is work that has focused specifically on, for example, Black sexual minority women's experiences. Medina Agenor, who's at Harvard, is leading some of the work in that area. I think, and that work is incredibly valuable and becoming more and more, I'm seeing it more and more in the literature that's emerging. I have a commitment to always recruiting. If I'm running a study where I'm recruiting my own participants and collecting my own data, I have a commitment to always aiming for diversity in terms of race and ethnicity, as well as in socioeconomic status. And I think sometimes that takes a little bit more time and effort, and there are specific strategies to use. It takes potentially some more creative thinking about how recruitment goes. So for example, in my study on prenatal care coordination right now, our first recruitment plan that the IRB helped us generate was to mail out letters to previous clients of PNCC. So we've mailed out paper letters. Now we're going to reach a certain group of people who received PNCC that way, people who have some level of housing stability, who are still at the address they were at when they enrolled in the program. And we're going to miss lots of other people who don't fit into that category. So as we see who responds to us, then we will do a second tier of a strategy about recruiting folks who are potentially experiencing even more marginalization. And unfortunately, those are often folks who come from racial or ethnic minority backgrounds, who don't speak English as their first language, who have more socioeconomic struggles, and things like that. So I think I'm deeply committed to that, and I think I'm very excited to continue learning through partners in the IRB and other experienced researchers about how to best do that. Yeah, thank you.
Other questions?
Thank you for your presentation. Generated quite a bit of interesting questions, so thank you for being here and for engaging with us. So I want to just follow up on what you were talking about in terms of reaching more diverse populations. You mentioned some interesting aspects, but I'm just wondering about community partnerships. Can you talk about your work in sort of building a sense of community partnership to then launch into doing more of this work and sort of in an intentional manner? Because we know that, if we're not doing it that way, then it can be a bit of a challenge. So if you can just kind of share about what you've done and how you plan to sort of move that forward in terms of building those community partnerships to then diversify your population for research.
Yeah. I think because of this projects that I've been working on since I came to UW, the way that I've approached building those community partnerships is really with the organizations that implement the programs I'm interested in. And again, I haven't led my own data collection in terms of this group of sexual minority women per se in the Madison area, but strategies that I've used elsewhere are things like just showing up at community events, talking with the folks who lead community organizations, finding out what community centers or gathering places that the community uses in specific locations, whether it's a specific city or region. And that work takes time and isn't always hard to predict how it will go. But yes, I think that because my work here that's been focused on Madison and Dane County as well as the state of Wisconsin has been so programmatic as the center of the research question, the community partnerships I've built so far here are really with the people who run and implement those programs. And even I'm sort of in the middle of data collection on the prenatal care coordination study, and building those connections with the nurses who implement PNCC here in Dane County has been just so enlightening and so important. I think every time you engage in that work, it just reminds you how deeply important it is to generate anything useful, right? Making the findings actionable and generating recommendations that people can use. So, yeah, thank you.
Okay, last question. Okay, seeing none, let's thank our guest for a great presentation.
you.